Hey there, welcome. This is Here's Your Good Health. My name is Linda Prezioso. I'm a nurse practitioner at Family Medical Center. Tonight I've got Dr. Sridhar with me. He's been with me before. He's a great guest. He's a urologist here at UNC Urology, is that?
UNC Health at
UNC Health
at Nash.
UNC Health at Nash Urology. That's
a lot
mouthful.
to say. It's a mouthful.
So I'm just going to say you're a urologist.
That works.
Welcome.
That
it's
works.
good to see you
Thank
again.
you.
Thanks for
it's
coming
my third
on.
time being here, and you know what they say? Third time's a charm.
That's right. That's right. So it's going to be a charming show
right.
tonight, you all. So Dr. Sridhar has been here how long now?
Let's see, I started 2021, so it'll be 3 years now. A little over, it's probably 3.5.
Okay.
Because it's towards the end of the year now.
Okay.
It's crazy. It's already
Yeah.
the end of the year.
And you have, well, I think you're the only urology office in town, but that has
Yes.
always been a very busy office.
And continue to be be
Yes, yes.
Yeah.
So we're going to talk about various problems that you treat.
That's right.
And but just give my audience just a little bit of a view, who you are, why you're here, how did you get to Rocky Mount, North Carolina?
Sure, yeah. So my name's Akshay Sridhar, right? And so I was born in India, came to the States when I was 6 years old, lived in Queens for about 5 years, moved to Plainsboro, New Jersey, which is central New Jersey near Princeton. Essentially grew up there, went to college, medical school, all of that stuff over there. Then I moved to residency as well. Then I moved to Rocky Mount for the job.
Really?
Yeah, honestly, this was the only interview that I took.
Really?
Yeah, I mean, I called a bunch of places,
Sure,
I had scheduled stuff, but this was the only in-person interview I did. And, thankfully, my wife organized everything. She's much better organization than I am. Dr. Dauber, who was here.
Yes, that's right. She's been on my show.
Yep, and so she organized everything. It's the first in-person interview I did, and this is due to Dr. Alkire. Him and I went to residency together.
Oh, really?
So he said there was an opening here, so I applied.
Okay.
And I just, I went here. I got sometimes you get a feeling. Right, you just get a feeling.
It was just a good feeling.
It was a good feeling, and I said, these guys seem like good guys, and I'm gonna, there has to be a leap of faith at some point.
Oh yeah.
And so I took that
course.
leap of faith,
Yeah,
and it's
yeah.
been paying off.
Oh, that's a great story.
Yeah, thank you. Yeah,
Yeah.
it was good. I'm very
Yeah.
happy, and the guys are awesome.
Now I know Dr. Pazek. I know of Dr. Pazek. I've
Sure.
never met him, but
Yeah.
I've talked to him. He took care of my ex-husband. Poor Bob, he had lithotripsy, and everything that
Okay.
could go wrong with lithotripsy went wrong. He
Oh,
got
man.
hematomas,
Yeah.
and he was in the
Sure.
hospital for several days. So Dr. Pazek was really good about calling me every
Okay.
day and
That's
giving me an
good.
update,
Yeah.
And so I really liked him just by talking to him on the phone.
That's wonderful.
And then I know of Dr. A.
Sure.
I haven't
Yeah.
heard, I've not met him either, but all my patients who see him love him.
He doesn't stop smiling.
Really?
He's just always smiling. Yeah, I've never seen him in a bad mood. Let's put it that way.
Really?
Yeah, he's always in a good mood.
Oh, I need to hang out with him.
I know. He just you know how they say somebody has a good vibe. He's got a good vibe.
He's got a good vibe.
That's
Was
right.
he there when you interviewed?
I interviewed actually through WebEx, through Zoom, but when I came in person, he was not there.
Okay.
No, he was with his wife lives in Virginia, so he was there, visiting his daughter and wife because she's still in medical school.
Oh, okay.
Yeah.
Okay.
Yeah.
All right.
But I didn't see him in person until I started.
All right.
Yeah, but he's a good dude.
Yeah, that's what I've heard. Someday I'm going to go over that office and just introduce myself.
Please do. We'd be
Yeah.
happy to have you.
Yeah, yeah. Because I knew a lot of, I've been in nursing for a long time. I used to work in the ER back in the day when everybody had to have call themselves,
Sure.
before hospitalists.
Yeah, yeah.
And so I knew them all because they'd walk through the ER. And
Yeah,
I
so you
did-
knew Mathis and
Oh,
all those
yes.
guys. Yeah,
Oh, yes.
Frobos. So those
Yes,
guys, yeah.
yes. Whitmer, I don't know if you ever met Bob Whitmer.
I've never met Dr. Whitmore. The only person I honestly met are Dr. Frobos and Dr. Mathis. Yeah.
And I think Frobos, I think his daddy was one of the original founders
believe
of
he
that
was.
of that group.
Yep.
So he's been around. He's a good old Rocky Mount boy, I guess.
Yeah.
He's
Same
not a
with Dr.
transplant
Pazak.
like we are.
That's right. Yeah, exactly.
Yeah. So what made you go into urology versus cardiology versus nephrology versus rheumatology?
Sure, yeah. I was going to, I guess, thinking initially cardiology because, why not? And then
I don't know.
I went through medical school, and then, during the third year is when you do your rotations. So I did my general surgery rotation. I realized I liked working, with my hands, because I have an engineering background. And so I said, yeah, maybe I'll go into this. And my friend from college was actually a urology resident at the program, and he essentially said, hey, so, this is really great. You can do abdominal surgery and everything, but why don't you try urology? Because you do similar things but different. You just focus on different organs.
Right.
And you have less emergencies. And so the moment he said less emergencies, it got my attention. I said, okay, yeah, that sounds good.
Yeah.
And so I did it, and luckily I liked it. I spent I think a day or two with the urology group there, and I liked it, and then I just, again, took another leap of faith, and I applied, and luckily I got in.
Well, your leaps of faith have proved to be very profitable.
They
for
have
you.
paid off quite
Yes,
well for me. Yeah,
yes,
yeah.
That's awesome.
Yeah.
That's awesome. And where did you meet Joanna Dalber?
I met her I was living in Cherry Hill, New Jersey at the time. It's in South Jersey. She was in Philadelphia.
Okay.
So,
Yeah.
that's where we met.
My ex-husband's
Yeah.
from Hamilton.
Oh, is he?
Yeah.
Okay. Very
So-
close to where I used to live, Princeton.
Yes,
Yeah.
that's right. I spent a lot of time in Princeton.
That's a nice place, isn't it?
It is.
Yeah.
It is. If you want to go visit New Jersey, they've got the best food, though. I can tell you that.
It's amazing.
I know.
There's a lot of
I
good
know.
food in New Jersey. Hoagies, we call it, hoagies,
Yeah, right.
subs.
Yeah, yeah.
Yeah, New Jersey has amazing food.
I know.
Yeah.
Those Italians know how to cook, man.
Yeah, pizza in New Jersey,
Whew.
it's very good.
All right, we got to get going, or I'm
Right, of
I'm
course.
going to
Yeah.
get hungry here in a minute. So, excuse us. I've got tea. He's
Sorry, I have
got
some water here. Yeah.
and these lights are hot. So tell me, what is urology? What is that study? What do you do?
So we treat surgical diseases of the genitourinary tract. So that involves the kidneys as well as the adrenals, which sit right on top of the
Right.
kidneys. The ureters, which are the tubes that connect the kidneys to the bladder, and then men, prostates, penis, scrotum, genitals, all that. Yeah.
Okay.
And we do female genitalia as well, depending on what the exact issue is.
Right,
Yeah.
right.
There's some crossover with gynecology.
Yeah.
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 So we treat all the surgical diseases you can think of. For those, we treat those, as well as medical diseases like urinary tract infections and
Sure.
kidney stone prevention, things
Right,
like that.
Right. We're going to talk about some of that. 'Cause
Yeah,
kidney stone
absolutely.
I think kidney stone is, anybody that's ever had one, I said there's two really painful processes that I've seen in medicine.
Mhm.
Kidney stone and shingles.
Yeah, luckily I've never had either.
I know,
And
me
so
neither, and I don't
hopefully
want
it stays
to.
that way. Well,
That's
if we
right.
keep drinking water, we should be fine,
Well,
at least
yes,
with kidney
this
stones.
is tea, green tea, so
Green
it's
tea,
nice
okay.
and healthy for
Okay.
me, water, I only drink coffee and water, and tea. When it's cold, I drink tea. I
Sure.
don't drink tea
Yeah,
in the summer.
it's comforting.
Yes, yes. So tell me, so you treat kidneys,
Yes.
but nephrology treats kidneys.
Correct.
So give me a little bit of differentiate them for me.
Yeah, no problem. So nephrology deals with the medical diseases of the kidney. Like for example, nephritis, people that have chronic kidney disease and require dialysis, nephrology handles all of that. But anything to deal with surgery, kidney stones, tumors on the kidney, what else? Any level of a physical obstruction of the kidney, because there's different ways that you can have obstruction. That's us.
Okay.
We deal
Yeah.
with that. So nephrologists are medical doctors. We are the surgeons of that.
Okay, well, that's a good way to look at it.
Yeah.
Yeah, okay. And so, let's see. So do you do surgery? That was one of my questions. So you do, and
I do surgery.
and then there's something about a green light laser. Do you know anything about it? Do you know
Yeah.
anything about a green light laser?
Yes, I do. Yeah, so that's called the vaporization of the prostate. So they use the green light for that. It's a good tool, so it's the conventional way. Let's back up for a second. So many men, every man, as he grows older, gets an enlarged prostate. as far as the rate of growth of each person's prostate, it varies, right? So some men's prostate grow at a different rate than other men. And sometimes as the prostate grows, it can grow inward. And what happens when it grows inward is the channel that the urine flows through from the bladder becomes more narrow. So generally speaking, the urine flows from the bladder through the prostate and then out through the penis. So if that channel within the prostate has become more narrow, the bladder has to work harder to push that urine out.
Right.
So when that happens, they start experiencing symptoms like frequency, urgency of urination, waking up multiple times per night to urinate, weak stream, having to strain to urinate. All of those symptoms are symptoms of an enlarged prostate.
And every man's prostate grows.
Yeah, it is
It's
a
just part of the aging process?
It's part of the aging process.
And it just depends upon, some have it and some get to this obstructive portion.
That's
and
right,
others
yeah.
don't.
And
Okay.
there's men with huge prostates that we've seen that don't have any obstructive symptoms, which is very, very interesting because their prostate's over 100 grams, which is a big prostate. And yet they say, yeah, I don't really wake up at night. My stream's pretty good. I have no problem. But then I see men that have, a 30-gram prostate and say, I'm waking up 3 to 4 times a night. It's very weird. I'm not going to lie to you. It's very weird. However, once we open up their prostate, create a larger channel within the prostate, those men inevitably do very well.
Okay.
Yeah, it's an easily fixable
And so you
problem.
always use that laser to do that?
Yeah, so now going back to the laser, there's various technologies that you can use to help create a larger channel within the prostate. So there's 2 ways to go about it, right? One, you can manipulate the tissue by pushing it to the side, and that's how you can create a larger channel. The other is by removing or vaporizing the tissue. The traditional way that it's been done, generally for smaller to medium-sized prostates, we're talking prostates that are between 20 and 70 to 80 grams, has been the TURP. That's called the transurethral resection of the prostate, right? The gold standard is what it used to be. The roto-rooter, a lot of people like to call it the roto-rooter, right? And so essentially what that involves is us going into the prostate with a telescope, technically an endoscope, and we shave the prostate. So by shaving the prostate, we're removing tissue and creating a larger channel inside the prostate, right? And so now, when I put the camera at the bottom of the prostate and I look up, I can see directly into the bladder without any obstruction, right? Prior to that, you would have all of the tissue blocking, so I wouldn't be able to see into the prostate. And now, if I can look into the prostate from the bottom, into the bladder from the bottom of the prostate, you can only imagine fluid, urine is going to go right through, right? And so that was the gold standard. Now, as the years have progressed, other technologies have come onto the market, one of which is the green light laser. So the green light laser is what we call a side-fire laser. Essentially what it does is you aim the laser beam at the tissue, and it vaporizes the tissue.
Really?
Yeah, it vaporizes it. And so it's really great for people that can't come off of blood thinners, like Plavix, Eliquis, right? Some people are still on warfarin, right?
Oh, God,
Coumadin.
yes.
And so those guys that really can't come off of it for various reasons, you can use the green light because it's very good at hemostasis. Hemostasis simply means stopping bleeding,
controlling
right?
the blood.
Exactly. And so it's very good at that. And so you can use that on those patients, right? Those are the higher risk patients. Then you can vaporize the tissue. I don't do the green light laser, but a lot of people do. The reason I don't do the green light laser is, one, we just don't have it at the hospital. But
Well, that's a good reason not to use it.
right.
To do it.
2, personally, there are better ways to do it, right? It's you have to do one thing consistently to become really good at something.
Of course.
Right? And so that's just not something that I've done consistently.
I got you.
Right? So what I've done more consistently are TURPs, right? Which is, we all learn how to do that. The Urolift, which I'll talk about. And it's called a holmium laser enucleation of the prostate. Also a mouthful.
Yeah, really.
Right? But I've gotten much better at the Urolifts, TURPs, and the HOLIPs. That's what I offer at our clinic. And people do very well with those, and avoiding all these other technologies. If you look at the BPH market, so BPH stands for benign prostatic hyperplasia, which simply means an enlarged
Right.
prostate.
That's right.
If you look at that market, as far as the technologies go for that, it is a booming market. There's a million things out there, and there's always new things coming out. It's up to us as physicians to understand which technology is actually good technology,
Right.
which is just hype.
Uh-huh.
Right? It's
Yes.
important to differentiate
Yes.
between
Yes.
the two. And which technologies are actually providing results versus, hey, this is the newest thing on the market.
Right.
I'm going to try it.
Right, yeah.
Right?
Yeah.
And so it's very important to understand that. And I think the only way to do that is you can try all of them, but you have to look at the data, of course.
Of course, of course. So, does any of the prostate ever grow back?
Yes, so it does, depending on what you do. So the gold standard, which was the TURP, generally they say within 10 years you may require another procedure.
Oh, really?
So it's good for on average, 10 years. It can last for longer, right? But we're looking at averages here. Now, with the laser enucleation, how is that different than doing a TURP? So a TURP, like I said, it shaves the tissue, right?
Right.
And generally what you want to do is you want to try and get down to what we call the capsule. The best way to describe it is this. Imagine an orange. You have the rind on the outside,
Right.
and then you have the fruit on the inside.
Mm-hmm.
Imagine putting your finger in the space between the fruit and the rind and rotating it 360 degrees. You separate that fruit
Right.
from the rind.
Mhm.
Then you could push the fruit out, but the rind stays intact.
Gotcha.
That's similar to what the prostate is like. So we can consider the prostate capsule the rind, the outer portion, right? And the inside, the fruit, we call that the prostatic adenoma. All of that tissue, the fruit, is what's causing the obstruction of flow
Right.
from the bladder, right? It's, if you look at a hose and it has dirt inside the hose, that dirt is occluding that flow, so if you look at the end of the hose, the stream is just kind of weak, right?
Right.
So we got to clear out that dirt. That dirt is the tissue in the prostate.
Right, right.
And so you can actually find a clear separation between those two things. And by doing that with the laser enucleation, where you actually core out the prostate, after that procedure, honestly, it doesn't grow back. It's very, very, very unlikely to grow back, let's put it that way.
Okay.
Versus a TURP, you may not necessarily get down as far as the capsule. So you may still leave maybe, a millimeter, 2 millimeters, 3 millimeters of tissue, which can over time grow again
Okay.
and cause
Because a millimeter of tissue is not very much.
it's not much. It's not much, but if you don't quite get down to the capsule,
Right,
it can potentially
right,
grow again.
right.
Yeah.
Well, I can see I'm not going to get anywhere near all my questions because, but I know everything I need to know now about a TURP and
Yeah.
BPH and enlarged prostate. So we're going to take our first break. And when we come back, we're going to talk to Dr. About more, well, I want to go into erectile dysfunction and low
Sure.
T.
No problem.
Because that's a big, it's a big problem. I see it a lot.
Sure,
And men don't
yeah.
want to talk to me about it because I'm a woman, but they do because they're desperate.
Yeah,
So,
fair enough.
All right.
Okay.
We'll be right back. Don't go away.
When Jay arrived at the emergency department with a hernia, he was in pain, scared, and unsure of what would happen next. That's when he met Dr. Clarice Monnier.
The way she conveyed, it was something that I could understand. She didn't talk over my head. She called me at home on her cell phone just to see how I was doing. They really treated me like family. I just can't say enough. I wouldn't be hesitant to come back here.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't arise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
America's Home Place is making your dream home more affordable with their November discount of up to $15,000 off the base model price. Whether you're seeking a cozy retreat or a spacious family home, we have the perfect floor plan to fit your lifestyle. And with endless options to customize, your new home is just waiting for your personal touch. Don't miss out on this amazing offer where style meets savings. Join us in celebrating our 1-year anniversary on November 8th from 4 to 6 p.m. to learn more.
Sorry, we've been laughing.
I mean, yeah.
Yeah, that's right. I'm not going to say what we're laughing about. Anyway, so I want to talk about erectile dysfunction
Sure.
and low T.
Yeah.
You know, the commercials are all full of low T and get this product
Sure.
and get that product and blah, 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 blah.
Yes.
And, you know, men, it's a big problem for a lot of my men.
Yeah.
And so what is it, what causes it, and what can we do about it?
So as far as the causes of erectile dysfunction or low testosterone, we'll start with low testosterone
Okay,
first.
all right.
So low testosterone, there's various causes, right? It could be due to medications that you're taking. So for example, people that are on chronic pain medications, that will lower their testosterone.
Will it?
Yeah, if you're on chronic opioids, you can have a low testosterone. That will cause that.
Really?
Yeah,
Huh, how about that?
right? The other is lifestyle,
Uh,
which leads to obesity.
Okay.
Right? So larger obese men will have a lower testosterone. That's because they have more adipose tissue, fat cells, on their body. And so what happens when fat cells, when they're creating the testosterone, is it gets converted into estrogen
Uh-huh,
through aromatase, which is located in the fat cell.
right.
Right? So when it gets converted to estrogen, then their bioavailable testosterone that's inside their blood is no longer available because it's estrogen. And that's why they start experiencing other things, right?
So obesity is really a key to low testosterone?
Yeah, absolutely.
Wow.
Obesity, an inactive lifestyle, very
Right.
stagnant. You're just sitting all
Right,
day,
right.
on your
Got to
couch.
move.
You got to move. And that's true with anything. I'm
Right,
sure you
that's
preach
right.
that all day.
Every day,
Right?
all day, every day.
And
yes.
so that's the thing, right? Speaking in general here, an inactive lifestyle can lead you down a path to various illnesses,
Of course.
right?
Yes.
And so, including low testosterone.
I didn't realize it for low T.
Yeah, so it can do that. So whenever I see an obese man in my practice for low testosterone, I first ask them what their lifestyle's like. If they say they don't really exercise, their health, their diet is really poor, first thing I say is you have to change all of these things.
Right,
You have
right.
to eat a healthier diet,
Right.
start losing some weight, get to the gym, do some resistance training, right? Resistance training, you'll start to build muscle, let your body produce its own testosterone.
Mm-hmm.
After all of that, if we're still having low testosterone, then we will talk about testosterone replacement therapy. So you mentioned that on the commercials, or really online, anywhere you read, yes, we can send you testosterone, so on and so forth.
Right.
Take this pill,
Right.
all of that, right?
Yeah.
Testosterone is a controlled substance,
Yes, it is.
right?
Yes,
and
it
so if these men, or rather these companies, are saying that you can just buy testosterone over the counter, that is incorrect. And so I don't want you guys going out there wasting your
I
money.
know, right?
It
Because
is
you
a-
don't know what you're getting.
It's a complete waste of money. These
Right.
are herbal substances. Don't do it. You should, if you want to start testosterone, or at least are curious about what your testosterone level is, speak to your healthcare professional. Let them check your testosterone level first. So what are some of the symptoms of low testosterone? Fatigue, low libido, really not wanting to do anything,
Right,
right? And
little
it can also,
depression.
yeah, and it can also affect your bone mineral density, all of
Yes,
these things.
yes.
And so, for all those indications, and if it's truly low testosterone and they've, with no other modifiable, lifestyle factors, then yes, they're a candidate for testosterone replacement therapy, which can come in various forms. Now they're actually making pills of testosterone.
Oh, are they?
Yep. And then the other forms are injectable or a gel, right? And you can also there's something called a testapel where you can place it under your skin and it gets absorbed over time.
Oh, really?
Yep. And
Do you do that?
we don't do that at our practice, but we do injections and gel, and I think
Yeah.
one of the reps for the pills came in, so we're gonna definitely hear about that.
Okay.
But those are the,
I gotta find out about that. That's interesting. to me.
Yeah.
It's much better than them having to get a shot.
Absolutely, yeah. And sometimes they can give the shot. A lot of times they can just do it themselves. It's
Yeah.
every 2 weeks, right? Or they can just come to our office and we just give it to them. But those are the things. Those are the indications really for treatment of giving them back the testosterone. So when someone comes in with erectile dysfunction, we always check a testosterone level to see if it's low. But generally speaking, let's say it is low and we start giving them testosterone replacement therapy, it may not necessarily cure their erectile dysfunction, because erectile dysfunction has its own factors. Why are someone having erectile dysfunction?
Right.
It comes down to various things. So cardiovascular disease,
Yes.
right? If you have a poor heart, if you have bad,
Poor blood flow to the heart, you're gonna have poor blood flow everywhere.
Exactly.
Right.
Right. So the blood flow, the blood vessels that are feeding your penis are small blood vessels. And so if you are having erectile dysfunction and you have not been diagnosed with cardiovascular problems, that's actually could be a indication that there's something else going on,
Such as?
coronary artery disease. If you don't know, right? You hear these
Right,
people.
that's right.
Oh, one day he was just staying there. And he dropped dead. Right? He had no idea that he had CAD. Was never put on a statin. Right? And so, but he had erectile dysfunction. So these actually could be indicators of something else in the body that's going on.
Right.
So cardiovascular disease can certainly cause erectile dysfunction for poor blood flow. 2, diabetes. If your diabetes is not controlled, right?
That's
If your
right.
A1C is in the 10s, 11s, you're going to deposit plaque in these blood vessels, again, causing poor flow. Not only will it cause erectile dysfunction, but diabetes will cause chronic kidney disease, will
Oh,
cause
it's
cardiovascular disease.
Blindness, I could go on.
Right,
People
exactly.
don't listen to me, they don't believe me.
Right, because it's easy to stay where you are. It's easy to be complacent, right?
Yes.
It's easy to just, I'm hungry, I'm going to eat whatever I want.
Yes,
What's hard to do is to actually change your lifestyle.
Yes.
And taking some proactive steps.
yes.
But that's one of the other causes of erectile dysfunction. And so there's various ways to treat it. One of which we were talking about earlier is Viagra and Cialis, right?
Right.
Of course, those are brand names. We won't go into the generic names here, but essentially they increase the amount of nitrates inside that area, which causes increased blood flow with blood vessel expansion and allowing you to more easily obtain and maintain the erection.
Right.
But sometimes those don't work all that well. I forgot to mention smoking, tobacco
Oh, I hate sweet tea and I hate cigarettes.
use. Right? So tobacco use can cause
Yes.
erectile
Oh,
dysfunction,
sure,
along with
of
the
course.
myriad of other diseases, right?
Yes.
A lot of people talk about cardiovascular disease, lung cancer, lung disease with tobacco use. But what people don't talk about is smoking can also cause kidney cancer, ureteral cancer, which is cancer in the ureter, which is a tube that connects the
Right,
kidney to the bladder, bladder cancer.
Is that
prostate
kind of, I've
cancer.
never heard of ureteral cancer.
Yeah.
Is it rare?
I guess compared to the others, yes.
Okay.
It's less frequent, but it exists.
Yeah.
And so you can have tumors within that tube, and that could be very directly linked to tobacco use, and generally find that with blood in the urine, but that's a whole other discussion.
Right,
But
right.
anyways, tobacco use can cause that. So these guys, they come to the office, I have erectile dysfunction. Okay, let's try this. What are your lifestyle? How are you exercising? Do you smoke? Yes, I've been smoking for 20 years. Okay,
Right.
well, you need to wean yourself off of cigarettes. It's harder. It's very hard. I'm not even saying that it's easy.
Right.
But I'm saying as long as you continue to smoke, the medications that I give you will not be that as effective.
Correct.
Right? It will not
Yes.
be optimally effective. So for it to be optimally effective, you have to stop smoking.
Yeah.
You have to change your lifestyle.
People want a pill to fix whatever,
Right.
Women want to lose weight. I don't want to change the way I eat. I don't want to exercise. I want a pill and I want to be a size 6.
Yeah.
It just doesn't work that way.
Right, and it's not an overnight or a quick fix.
No.
Right, it takes work, and
Yes.
you can do it. You can do it. It's just a matter of getting on that track and staying consistent. And so That's one method of treating erectile dysfunction through pills, but sometimes pills don't always work for various reasons, right?
Right.
Sometimes it initially works, but then maybe over time it's become less effective. The other thing, a mode of treatment for erectile dysfunction is you can take the pills in conjunction with something called a vacuum erectile device, which is basically a penis pump, right? You can get it at any online retailer. It essentially creates a vacuum and puts your penis on stretch, allowing more blood flow.
Does it hurt? Well, you don't know. You've never.
I don't know. I can't say from experience, but the men that have used it they don't really say it hurts, you know.
Okay. Yeah.
And so that's one option, right? And if that doesn't work, then we can move on to something else. It's called an intracavernosal injection. So when you look at the penis, right? If you look at a cross section of a penis,
Right.
you'll see 3 tubes. So you'll see 2 large tubes at the top, and this is 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. You'll see 2 tubes that are called the corpora cavernosa. Those are the tubes that get engorged with blood, that give you the erection, right? And then in the middle, and then the bottom, you'll find another tube. That's the urethra. That's the tube they pee out.
Right. Right.
So an intracavernosal injection is simply an injection directly into one of those bigger tubes, creating, increasing the blood flow in that area, and then giving you an erection within a few minutes after some stimulation. And so it generally lasts between 30 to 40 minutes. It's a good option for men that can give themselves an injection or have their partner give them the injection.
Sounds like it hurts.
It can, but if they're diabetic, they're
don't
already
feel
used
it.
to. Yeah, they're already used to giving themselves, if they're on insulin
Yeah,
at least.
that's right. Yeah.
That's one option, right? And that's a good option. The last option is we put an implant in the penis. So those 2 tubes, the hollow tubes that I talked about, we essentially make an incision and dissect down to those tubes, and I hollow out those tubes. Then I could put inflatable cylinders in each one of those tubes, which is connected to a pump, which we place in the scrotum. And then that pump is then connected to a reservoir of fluid, right? Which I place in their inguinal region. And essentially the way it works is once you connect all those things, it's a closed system. So you just press the pump, and it takes fluid from the reservoir and puts it in the cylinders, and you inflate the cylinders, you get the erection. It'll stay up for as long as you want it to stay up. And then after you're done, you just simply press the button on top of the pump, and the fluid is evacuated from the cylinders back into the reservoir. But after that, you can't, Viagra, Cialis, these things won't work anymore because the blood vessels that were there, the architecture is all gone.
So once you do that, that's it.
That's it. And those are generally meant to last for about 10 years.
Do you do those here?
I do. Yeah. We offer those at UNC, at Nash.
So do a lot of men choose that?
I think a lot of men are scared when they hear about that, but I think with more education and mutual decision making, they become a little bit more comfortable.
Yeah.
And I've done quite a few.
It's all about education with anything, isn't it?
Yeah.
You've got to know. You don't know what you don't know.
Information is power.
Absolutely.
Yeah.
Absolutely. Wow. Well, that was quite a discussion, wasn't it,
Yeah.
y'all? I've learned a few things here. So, we're going to take our next break because we're at a good breaking part. And when we come back, we're going to talk about, I don't know, maybe some cancer.
We can talk about cancer, sure. No problem. We'll
and-
talk about prostate cancer and its screening and all of that. Yeah.
All right. Yeah, because that's really important too.
Sure, absolutely.
All right. Don't go away. We'll be right back after word from the sponsors. Hang on.
When Anita needed surgery, she struggled to find a doctor who made her feel at ease. Then she met Dr. Stephen Grant.
His bedside manner and the way he treats his patients was fantastic. He was different from everybody else I'd ever seen. He's compassionate. He really cares about his patients. I told him, you were my guardian angel. My experience with Nash was A+. So then the surgery I need here on out, give me a blank piece of paper, I'll sign it. I want you to do it.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't rise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
Make any day special by coming into Ribeye Steakhouse in Nashville. Come on in and enjoy our legendary tender and juicy Omaha Angus ribeyes. And try and share our seafood entrees, your choice of shrimp, flounder, or oysters. And especially don't forget our famous salad bar with all your favorite fixins. If you want to give that someone special something to revel in, Ribeye's gift certificates can be made to order. And as you're looking for somewhere to host a business meeting or special event, you can reserve the Angus Room. Ribeye Steakhouse of Nashville, over 10 years of great food.
All right, well, now we've learned everything we want to know or don't want to know about erectile dysfunction. I personally wanted to know about it for my patients.
Yeah.
And it's a big deal.
It's a big deal. People don't want to talk about it.
Right.
For its obvious, nature.
Right.
It's very intimate, but it can cause problems in a relationship.
It sure can.
And so there's things we can do about it.
That's right. Well, we're going to move on to more about the prostate, and I'm just going to let Dr. Sridhar go ahead and expound on that.
Yes, so specifically prostate cancer. Generally we start screening at 55 for prostate cancer. The way we do that is by checking a PSA. That's a prostate-specific
I thought it was 50.
antigen. It depends on which guidelines you're looking at.
Okay.
Right, each guideline tells you something different.
Okay.
Each society tells you something different.
Of course.
USPSTF came out, I don't remember exactly when it was maybe 5-6 years ago, and they came out and said it's a shared decision-making process, which it is, right? You should talk to your patient about it and say, hey, listen, we can start screening for prostate cancer by doing this one test. But if they didn't want to be screened, then obviously we don't do it. But we found that once that recommendation came out and less primary care providers were checking the PSA, of those that were checking at a later date, these guys were having more aggressive prostate cancer.
Really?
Because we weren't screening and catching earlier. And so, again, it's still a shared decision-making process. You should check. But it's simply a blood test, right?
It's just so simple. You get it along with your
Everything
other,
else.
yeah.
Everything else, right? But I guess the issue, if you want to call it that, or the concern, I guess is a better word, is the cascade of events that it can initiate if the number was high, right?
What do you consider a high number?
Historically, it's been anything 4 and above.
Okay.
Right, is what we would consider high. But we're realizing it really runs the gamut. Because there's guys that I've seen that have a PSA of 1 that have actually had low-risk prostate cancer, But no one would have ever checked. If you were just checking the 1,
That's right.
why would you check for,
right.
why would you do a biopsy?
Yeah.
There's no
Yeah.
indication for
Right,
that.
right.
And so we're learning a lot about prostate cancer, and the treatment of prostate cancer is always evolving, right? If you look at now how we treat prostate cancer versus even 5 to 10 years ago, it's different.
Wow.
It's totally different. So the guidelines are always changing. Now, as far as screening goes, you check a PSA, and generally, like we said, 4 and above is considered elevated. And so if that is the case, then that prompts that cascade event, and you refer to a urologist, right? Generally speaking, we repeat that PSA because we like to trend it.
Of course.
We don't like to just go based on one
yeah.
number, right? So we'll trend it, and if it's still elevated or if it's borderline, what we used to do was just jump to, okay, let's do a biopsy. Let's do a transrectal ultrasound guided biopsy. Simply what that means is there's an ultrasound probe that goes in the rectum because the prostate sits right on top of the rectum. And that's the best way to access the prostate,
Right.
for a biopsy at least.
Right.
Well, one of the ways. And so they would do that biopsy, and yes, cancer versus no cancer, right? That would be the diagnosis. The prostate biopsy is not without its risks. There's risks and benefits for any kind of procedure that you do. The biggest risk of that is a life-threatening infection, right? That will end you up in a hospital
Right,
and can
right,
potentially
that's
cause
right.
death. The risk of that happening is very low, but it's not zero. And so that's one of the things that you have to, talk to each patient about, to, that way they understand and they can have those expectations, and also they'll know what to do. Specifically if they have a
Right.
fever, you go straight to the hospital, you'll need
Sure.
IV antibiotics. But we always give antibiotics before we do the biopsy to prevent that from
Sure,
happening,
of
and the
course.
risk of sepsis, which is the infection, is quite low. So for guys, that's what we used to do, but now, if you have an elevated PSA, trending it, still elevated or borderline, we get an MRI of the prostate.
Oh, okay.
Yeah, we get an MRI of the prostate, which will preempt the biopsy. And what we're looking for on the MRI is any clinically significant lesions. So essentially what we mean by that is there any prostate cancer in there that can cause you physical harm? So that's what it's meant to look, really, find, clinically significant prostate cancer.
Right.
Because when you get diagnosed with prostate cancer, you get stratified into different risk categories, right? And the categories range from very low risk to very high risk. Generally speaking, for the very low risk, and the intermediate category called favorable intermediate, you don't necessarily need to do anything. You can watch it. You can check a PSA every 6 months and then do a biopsy every year to ensure that the cancer's not becoming any more aggressive, and the PSA is not rising.
Do you do those biopsies in your office, or it has to be done at the hospital?
We do it in the office.
Okay.
Yeah.
Are they painful?
Are they painful? We numb up their prostate, so really they shouldn't have
sounds
any.
painful.
That part is a little bit
Yeah,
uncomfortable,
yeah,
but after that they
okay.
just feel some pressure.
Okay.
Yeah.
Okay.
But, we now have this MRI, which tells us, one, if there's a clinically significant lesion, and two, how big the lesion is, and three, where it's located. So now you can actually do a targeted biopsy.
Oh, okay.
Yep, so that's called an MRI fusion prostate biopsy. I'm all about, mouthful of words here.
You really are.
Right? That's what it's called. So an MRI fusion prostate biopsy. So essentially what they do is they take the MRI image, they overlay it on top of the ultrasound, and then that way they can target that one area of interest.
That is fascinating.
Yeah. And so that's really now becoming the standard of care.
Okay.
As opposed to doing just a blind, transrectal ultrasound biopsy.
Right.
They actually do that through the perineum, which is that space between the end of the scrotum and the rectum.
Right.
Right. So they're in a different position. The probe still goes in the rectum, but they're just positioned differently. We don't have the technology at UNC to do that yet, at least UNC Nash. But I send these guys over to Chapel Hill
Okay.
to get that done.
Yeah, okay.
And so I find that that's a better way of doing it because you get a better result,
Yeah.
right? And so they have an elevated PSA, right? So I get this MRI of the prostate, but it doesn't show anything. So I'm like, okay. So at this point, studies have shown that I just spared you. I don't think there's any indication now to do a biopsy because I'm not seeing anything on the MRI.
Right.
That doesn't mean you don't have prostate cancer. It just means you don't likely have anything in there that can cause you harm or any aggressive form of prostate cancer. Specifically,
So there are different forms of cancer in the prostate.
yeah, it's done by Gleason grade, right? And so there's different numbers associated. So when you get diagnosed with prostate cancer, you have a Gleason score, right? And that's 2 numbers. So it's what you see, the way the numbers are done is how it's arranged, how the cells are arranged under a microscope. So when they do the pathology, look under the microscope, there's different patterns, right? There's 4 different types of patterns. So is it pattern 1, pattern 2, 3, 4, and 5? And so what is the primary pattern that I'm seeing? So that will be the first number. So let's say it's a 4. Primary pattern 4, okay. What's the secondary pattern that I'm seeing? Oh, it looks like a pattern 3. Okay, so then that score is going to be 4 plus 3, which is a Gleason 7. And that is clinically significant. But if it was just a pattern 3 and a pattern 3, that's a Gleason 6, that's not clinically, that's
Right.
that may not show up on an MRI. But that's less aggressive cancer. That's less likely to grow and spread quickly. So those can be watched. And so if the MRI doesn't show anything, we just spared this guy a procedure,
Right.
and we can just check a yearly MRI and just check his PSA.
Wow, that's awesome.
Yeah.
So what is the prevalence of prostate cancer like in Nash and Edgecombe County? Do you know?
As far as the numbers, I don't. It's a good question. I don't know the numbers, but it's a relatively higher prevalence in this area compared to, I believe, other areas of North Carolina.
You think it's our terrible diet we eat in this city?
Potentially. I mean, potentially, right? There's, as far as the causes of prostate cancer, it varies. There's definitely various external environmental factors that can cause it, but also mutations,
Yeah,
right? As every cell divides,
Right.
each cell replication is not perfect.
that's right.
People that don't smoke, people that never touched a cigarette a day in their life, we see them with bladder cancer. It's less likely that they'll get it, but why did that cancer occur? From a mutation in a cell that has just overgrown.
Right. So, speaking of bladder cancer, I guess there's various degrees of that too, but some people have to have their bladder removed, right? And they have
Yes.
a bag on the outside, kind of like a colostomy?
Yeah, that's exactly right, yeah. And so, with respect to bladder cancer, again, there's also different types, right? So the main thing...
It's never A and B. There's
It's-
always, all this little gray stuff in between.
Yeah, but it can be A and B if you categorize it in a larger category. So there is non-muscle invasive bladder cancer.
Of course there is.
And then there's muscle invasive bladder cancer. Those would be the two big categories. So the superficial lesions, which don't invade the muscle layer, is non-muscle invasive. Those, you don't need to take the bladder out. Those you resect. If it hasn't invaded the muscle, hopefully we've gotten all of the tissue. And then you could, depending on how, what the pathologist says, whether it's, high grade, you can give them, and then you stratify them into low risk, medium risk, high risk, right? And then you can, based off those risk categories, you treat them appropriately. But if it's non-muscle invasive, there's things we can do right after we resect. We can put a chemical in there. It's called gemcitabine, or we can do mitomycin. That's just another chemical. Essentially, it's like intra bladder chemo. It's like chemo that stays only in the bladder and then it comes out. And you're supposed to really do it within 24 hours of a resection. And essentially, what that particular thing does is it prevents the recurrence of the bladder cancer. So it prevents it from coming back. That's that. Now, if it's a high grade and they're in higher risk, there's something called BCG. You've all heard of the BCG vaccine, right? For tuberculosis and all that. But this BCG actually goes directly into the bladder, and we do it in over a 6-week course, and it's just once a week, and that's called the induction course. And what the BCG does is it essentially creates an immune response within the bladder, so the body can fight any other potentially cancer cells that are in there, and that's for higher risk lesions. And then we just watch them, and after that we simply look inside the bladder every so often, depending on which protocol you're using, to ensure that there's nothing else. The difference between mitomycin, gemcitabine, and BCG is BCG not only prevents recurrence, but it also prevents progression. Progression meaning it going into the muscle layer of the bladder.
Right.
So that's the difference.
So what's your preference? Is it kind of case by case?
So we have gemcitabine at the hospital. So that's what we do. Yeah, and if they're high grade, then we put them on a BCG schedule. If they're high risk, yeah. So now, let's say that we resect it and the tumor has invaded the muscle layer of the bladder. Standard of care generally has been what we call, neoadjuvant, which simply means before surgery. Chemotherapy. Neoadjuvant chemotherapy, and then bladder removal. So that's a huge surgery.
Can you put the chemotherapy right in the bladder, or does it have to go?
No, that's IV.
It's intravenous.
Intravenous
Okay.
chemotherapy. Yep.
Okay.
Yeah. So they would do a course of IV
Sure.
chemotherapy, and then they would undergo a cystectomy, which is removal of the bladder.
Right.
But that's a big surgery, and I'm going to tell you why. Because remember, the urine is made in the kidney, goes down the tubes,
Yep.
and then collects in the bladder.
Right.
Now, if I remove the bladder, where is that urine going to go?
Right.
Directly into the body. So we got to
We
figure out a
can't
way
do
for it
that.
to. That's right.
That's
so we got to
waste.
figure out a way
Yep.
for it to come out.
Yep.
One way for it to come out is we actually take a piece of small bowel and we fashion it into a little tube, tubularize it, and then we connect those ureters
Mm-hmm.
into that. And then we bring it out like a colostomy, but it's called a urostomy.
Right.
And then the urine drains through there.
Mm-hmm.
So that is one way to reroute the urine. And there are, that's called an incontinent diversion. That because the urine is always flowing. There's no control.
Right.
They're incontinent.
Yep, I got you.
Then there's continent diversions. And there's different ways to do that. And so one of which is very similar, right? You have the piece of small bowel and you have a pouch inside. But then you have a length of, you can use the appendix, and you basically tubularize it to the skin. And in the skin, rather than having a larger segment and the urine just coming through, it's just a little hole that you can put a catheter in and then drain it, right? So that's called an Indiana pouch, and that's a continent diversion. The other continent diversion is a neobladder, where you basically take some bowel, you
make
open
a
it up,
neobladder.
make it into a bladder, and then you reconnect it there, and you connect that to the urethra, which is the tube you pee out of. It's pretty cool how they do these things, but those are bigger surgeries.
Yeah, and so those all go to Chapel Hill?
Yeah, we don't do that here because it's you need to go to the ICU generally afterwards.
Sure.
And so you need people there all the time. At Chapel Hill, they have the resources and they have residents that are there.
So you got somebody 24/7?
Yep.
Instead of you having to be on call 24/7?
Exactly. Yeah. So we generally don't do those here.
Yeah.
We send those to Chapel Hill.
Well, we do a lot here, but there's a lot that has to go out too.
Yeah.
Even cardiology, we do a lot of UNC,
Yeah.
provides cardiology here.
Absolutely.
We have an absolute awesome cardiology department, but there's certain things that can't get done here and have
Yeah.
to go to Chapel Hill. And I'm very grateful for Chapel Hill.
Thank
I'm very
goodness for our
grateful for Greenville.
location.
I'm very grateful for
Yeah.
Duke. We are blessed
Absolutely.
to have all those tertiary care
Yeah,
centers so close.
we are. We really are.
Yeah. So, all right, give us a little, I was going to ask you, when I went to school, I had to learn how to do a prostate exam. Do we still do prostate exams, or we can just do the PSA?
You can do a prostate exam.
Men
Definitely
hate
do
those.
a PSA. Yeah, of course. Right. And so you can do that, but as far as the amount of information it will fetch you is, it really depends on, not everyone's fingers that long, and so you can only reach so far up
That's
if you have
right.
small fingers.
I got short little fingers,
Right,
stubby
same,
fingers.
same
yep.
here. And, it's historically, you can say, yeah, this prostate is this size. Really, if you're not feeling any bumps or nodules, then that's fine.
Yeah.
But if someone has an elevated PSA and you get an MRI, it'll show up.
Yeah.
If anything's going on, it'll show
Yeah.
up.
I mean, I prefer to do just the PSAs. My men prefer for me just to do the PSAs.
Yeah.
So,
And I think it's going towards that, where, MRIs are becoming much more prevalent and popular,
Yeah.
as opposed to us. You can't diagnose
Right.
with a finger.
Right. All I can do is say, feels a little lumpy, I'm sending him to you.
Yep, and that's fine.
Yeah. There's a reason I'm the Jill of all trades. I tell my
The
patients
Jill of
that
all
all the
trades.
time.
Okay, yeah,
Well,
I
I'm
like
not a
that.
Jack, I'm a Jill.
That's right, yes.
So I'm the Jill of all trades and
Yeah.
a master of none, and I send my folks to the masters like you. That's what it's all about, right?
That's right, yeah.
Yep.
But if somebody asked me how to manage diabetes, I would say, hey,
Call Linda.
I'm going to send you. Linda can take care of
Linda
it.
can take care of that. That's right. Well, thanks so much. It's been a great. Every time you come, I learn more. You're a
Well,
smart
no problem.
fella.
Thanks for having me here. I appreciate it.
Yeah, it's great. It's great. So, all right, we're done for tonight. We will see you next week with more of Here's to Your Good Health. See you next week.
All right. Take care.
Hernia, he was in pain, scared, and unsure of what would happen next. That's when he met Dr. Clarice Monnier.
The way she conveyed, it was something that I could understand. She didn't talk over my head. She called me at home on her cell phone just to see how I was doing. They really treated me like family. I just can't say enough. I wouldn't be hesitant to come back here.
Learn more at nashsurgery.com.
We're in our 18th year of practice at the Hammer Chiropractic Center, and we've seen over 15,000 different people in the Rocky Mount area. 40% of headaches actually come from a neck problem. Many patients come in taking multiple aspirin, over-the-counter medications and such a day, and we can get you to stop doing that and actually fix the problem so the headaches don't arise anymore. A lot of people think chiropractic hurts. It does not. Most of the people come in and they feel great when they leave.
America's Home Place is making your dream home more affordable with their November discount of up to $15,000 off the base model price. Whether you're seeking a cozy retreat or a spacious family home, we have the perfect floor plan to fit your lifestyle. And with endless options to customize, your new home is just waiting for your personal touch. Don't miss out on this amazing offer where style meets savings. Join us in celebrating our 1-year anniversary on November 8th from 4 to 6 p.m. to learn more.